Here's a dirty little secret about joint replacement. What actually dictates how well your recovery goes? A lot of people think it comes down to where the incision is or whether a robot did part of the surgery. Honestly, it's not. The things that really move the needle come down to three factors, and most patients have never heard of any of them. Let me walk you through them. The first factor is the arthrotomy, how we open the knee. There's a thin layer of tissue around the joint called the capsule, and the way we get through it matters more than you'd think. The traditional way cuts straight down through the quadriceps tendon right next to the kneecap. It's called a medial parapatellar approach. It works, and it gives great exposure, but you're dividing part of the muscle tendon unit that straightens your leg. The alternative is to go underneath the muscle instead of through the tendon. That's the subvastus approach. Lately, it's been marketed as the Jiffy knee. We slide under the vastus medialis, move the kneecap aside, and the quadriceps tendon stays intact. Now, despite the flashy name, this is not new. It's been around for more than 20 years. And here's why it matters. It's one of the only approaches that research has actually linked to a faster early recovery. You get your straight leg raised back sooner, less blood loss, better early motion. You may also hear about a lateral approach being marketed as the new thing for quick recovery. Two honest points. One, it hasn't been shown in our literature to do that yet, and two, it's actually over 30 years old. Most surgeons set it aside because it makes the bone cuts and implant placement harder to do accurately. So of the options out there, the subvastus is the one with the real evidence behind it. The second factor is alignment, the angle we set the new joint surfaces to. There are two philosophies here, and this is where I want to slow down because it genuinely affects how your knee feels. The conventional way is called mechanical alignment. We cut every knee to the same neutral, perfectly straight target. It's reliable and it's been the standard for decades, but most people's knees aren't perfectly straight to begin with. So to make the implant balance on that straight blueprint, we often have to release or loosen the ligaments. The other philosophy is kinematic alignment, or KA, instead of forcing your knee to a standard blueprint. We resurface the worn out cartilage but keep your knee's own natural angles, your original joint line. Think of it like recapping the tread on a tire without changing the alignment of the wheel. Why do I favor it for recovery? Because when you preserve the natural shape, you need far fewer ligament releases. And studies show patients tend to have less pain in those first weeks, good early motion, and a knee that just feels more like their own. There's even a score for that, the forgotten joint score, and it tends to run higher with kinematic alignment. I'll be straight with you. By a couple of years out, a lot of the numbers even up between the two methods. And kinematic alignment demands precision, which is exactly where technology like navigation or a robot earns its keep. But for that early experience, comfort, a natural feel, getting moving, the edge goes to kinematic. The third factor is what happens around the surgery: anesthesia, nerve blocks, and pain management. This one might matter most of all because the earlier you can move comfortably, the better you recover. The modern approach is multimodal. We layer several gentle methods together instead of leaning on heavy narcotics. A few pieces, a spinal instead of full general anesthesia for many patients, less nausea, less grogginess, an easier wake up. An adductor canal block. This is a big one. It numbs the pain nerves to the knee but spares the quadriceps muscle, so your thigh still works and you can walk the same day. That's a real upgrade over the older femoral nerve block. Then we add a numbing injection right around the joint during surgery and a medication called tranexamic acid that cuts down bleeding and swelling. Put it all together, and most patients need far fewer opioids, clearer head, fewer side effects, faster progress in therapy. So if you're thinking about a knee replacement, don't get lost in the marketing about incisions and robots. Ask your surgeon about the three things that actually drive your recovery: how they open the knee, how they align it, and how they'll manage your pain. Get those right. Preserve the muscle, respect your knee's natural alignment, and keep you comfortable enough to move early, and you set yourself up for the smoothest recovery possible. If this was helpful, follow along. I break down the things about joint replacement that most people never get told.